Bismillahirrahmanirrahim. Now I am going to discuss the pathogenesis of candidal infections of the urinary tract. If there is hematogenous spread to the renal parenchyma, there will be formation of microabscesses in the renal cortex. Then the yeast will penetrate glomeruli and enter proximal tubules, from where the fungus will shed into the urine. If the host is immunocompetent, it will typically eradicate or clear the infection. In case the individual is immunocompromised, they will be unable to clear the fungus. In this kidney specimen, microabscesses can be seen across the whole kidney. These small white dots are actually microabscesses. This is an histopathological slide from a microabscess. Here, the virus is being shown as gray-brown under methamine silver stain. Ascending candidal infection usually occurs in patients with urinary tract obstruction. In addition to this, the virulence factors like adherence and biofilm formation also increase the infection risk. There occurs a unique syndrome in patients with kidney transplant, in which the source of Candida is from the contaminated donor kidney. In this syndrome, arthritis develops with formation of aneurysm and potential rupture. This syndrome leads to early graft loss and high mortality in transplanted patients. Microbiology of Candida in UTIs. Species distribution in Candida urinary isolates. 50% to 70% of the isolates are Candida albicans, while Candida glabrata accounts for almost 20% of the isolates. Here, there is an important point that Candida glabrata is more prevalent in patients who are older, diabetic, kidney transplant recipients, and who have prior exposure to fluconazole. Candida tropicalis and Candida parapsilosis are less common. Other species are even rarely isolated. Fluconazole susceptibility. Candida glabrata and Candida cruzae are usually resistant to fluconazole, while Candida albicans, Candida tropicalis, and Candida parapsilosis are susceptible to fluconazole. What is the importance of knowing this susceptibility? The importance is that we should try to identify the species because it will guide us to choose appropriate antifungal agent to treat the infection. Clinical manifestations. Majority of patients with candiduria are usually asymptomatic and they do not have infection. Less than 5% of candiduria cases present with UTI symptoms, and these symptoms depend on whether the lower urinary tract is involved or the upper. In case of lower urinary tract involvement, that is, patient is having cystitis, the symptoms will be similar to those observed in bacterial cystitis. For example, there will be dysuria, increased frequency, urgency, and suprapubic discomfort. If upper urinary tract is involved, patient will present with fever, chills, and flank pain. Complications of candidal infections of the urinary tract. Patient may develop urinary tract obstruction because of the formation of bezoar or fungal ball formation in the bladder or collecting system. If patient develop hematogenous spread to the kidney, then the patient will have systemic symptoms, and the typical symptoms of UTI will be absent. The systemic symptoms will include fever, chills, and hypotension. We face a diagnostic challenge in terms of differentiating contamination from colonization versus invasive infection. The easy step we can do to differentiate contamination from colonization or infection is to repeat the urine culture. If the repeated culture show the persistence of candiduria, then it is either colonization or invasive infection. Urine collection technique challenges. Some patients find it difficult to have a clean catch. In such cases, we can use sterile bladder catheterization. If patients have indwelling catheters, we should replace the catheter and collect new sample the next day. What is the role of quantitative cultures in diagnosis of infection versus colonization? Actually, there is no definitive cut-off coliforming unit per ml which might differentiate infection from colonization. Counts as low as 10 to raise power 4 cloniforming unit per ml can indicate infection in patients without indwelling catheters. The presence of pyuria is not a reliable marker of candiduria. It can be useful in patients with no catheter or concurrent bacteriuria. We should also keep this in mind when sending a urine culture for Candida, that Candida glabritis is a slow growing organism. It requires almost 48 hours for colony visibility. So what is the importance of this? The importance to know this is that most of the laboratories usually discard the urine cultures at this point when the colony for Candida glabrata starts to appear. Therefore, if we are suspecting this strain of Candida, we must inform the lab that they should do the culture for a long duration. What is the role of imaging such as ultrasound or CT scan in diagnosis of urinary tract disease caused by Candida? Ultrasound and CT scan are usually helpful in identification of obstruction or fungal balls in urinary tracts. What is the role of cystoscopy and biopsy in diagnosing candidal infection or colonization of the urinary tract? Cystoscopy can assess inflammation, and the biopsy will help find the extent of invasion in bladder wall. This ultrasound image is showing dark black fungal balls in the ureter and pelvis. This cystoscopic image is showing the inflammation of the bladder caused by candidal infection. Redness is showing the inflammation, while these white patches might be the Candida itself.